So this is part 3 of ABG series. Here we are going to discuss only about metabolic acidosis. We will try to learn with an interesting story, but before explaining the story, we will start with a patient who was found unresponsive at home. He arrived at the hospital at 7 p.m. and was unresponsive to pain. On examination, patient comatose. BP normal, GRBS was also normal, liver and renal function tests were also within the normal limits. A CT scan done and CSF analysis were also normal. The only abnormalities found were mild electrolyte imbalance and ABG results showing metabolic acidosis. So what could be the probable diagnosis in this case and how would you approach it? The patient is unresponsive and our only clue so far is the presence of metabolic acidosis. So we will review this case after some discussion. Last time in part 1 we discussed what actually happens in metabolic acidosis. As I mentioned earlier, our body has two types of acids, volatile and non-volatile. When the level of non-volatile acids in the body like sulfuric acid, phosphoric acid exceeds the normal range, it results in metabolic acidosis. Metabolic acidosis occurs when there is an excess of non-volatile acids. On the other hand, when volatile acids like carbonic acid or carbon dioxide are elevated, we call this condition respiratory acidosis. When a patient develops metabolic acidosis, it means the hydrogen ions in the body are elevated. These are all hydrogen ions. Normal range is 40. So the normal acid level is 40 nanomoles per liter. So when these hydrogen ions are elevated, the body must work to reduce them to bring to the normal range of 40. So the body has a buffer system that can accept or release hydrogen ions. Bicarbonate is one such buffer present in a concentration of 24 mg per liter in the body. Bicarbonate binds with hydrogen ions to form carbonic acid, which then split into water and carbon dioxide. This process quickly neutralizes hydrogen ions, thereby improving pH, means reduced acid level. So however, as bicarb is used up in this process, its level begins to drop. So when you see low bicarbonate in an ABG, one reason could be that the patient has increased non-volatile acids or metabolic acidosis. In metabolic acidosis, bicarb will be low because it has been utilized to buffer or neutralize hydrogen ions. It happens only when non-volatile acids are more. After some time, the body employs a second mechanism to reduce the acid load. Since we have volatile acids in our body, the patient will start hyperventilating to expel some of the volatile acids. This reduces the overall acid load in a process called respiratory compensation. So in metabolic acidosis, pH will be low, bicarb will be low, and PaCO2 also will be low. The pH is low because there is an excess of hydrogen ions. Bicarbonate will be low because it has been utilized for buffering or neutralizing hydrogen ions. And PaCO2 will also be low due to compensation, as the patient will start hyperventilating to expel carbon dioxide. As I mentioned before, remember these arrows in metabolic acidosis all are on the lower side. In metabolic acidosis, pH is low, bicarb will be low, and PaCO2 also will be low due to compensation. Now look at our patient's ABG. pH is low, indicating acidosis. The bicarbonate is low, confirming that the patient has metabolic acidosis. And PaCO2 is low, could be due to respiratory compensation. So this patient has metabolic acidosis. And what is next? Next, we need to determine if the patient has only metabolic acidosis or if there are additional disorders present. ABG can sometimes reveal multiple hidden acid-base disorders. To assess this, we use the formula I mentioned earlier in part 1 to calculate the expected fall in PaCO2 in this particular ABG. So the expected PaCO2 will be 1.5 into bicarbonate plus 8. If the measured PaCO2 matches the expected value, then the patient has only metabolic acidosis, as the PaCO2 fall is consistent with expected compensation. So here it is 29, that is what we expected. So the patient has only metabolic acidosis. But if you see a PaCO2 that is higher than expected, for example, if the value is 40, then the patient has an additional respiratory acidosis also. So here, in that case, the patient has metabolic acidosis and respiratory acidosis. And if the PaCO2 is lower than expected, like 20, in that case, the patient has an additional respiratory alkalosis also. So here the patient has metabolic acidosis and respiratory alkalosis also. But in our case, and the ABG shows that the patient has only pure metabolic acidosis. And now what? What should be our approach? Here you should know that the metabolic acidosis can be caused by 4 main mechanisms. So one is the increased loss of bicarb from the body, as in diarrhea. If we lose bicarb from our body, as in diarrhea, how does metabolic acidosis occur? Normally, bicarbonate acts as a buffer, helping to neutralize hydrogen ions. However, if the bicarb level drop, like in diarrhea, hydrogen ions will start to accumulate in the body, leading to acidosis. Second is increased production of acid, as in ketoacidosis. In this case, a large amount of acid is added to the blood. Third is the infusion of acid, such as through certain IV medications. And 4, failure to excrete acids, as in renal failure. Normally, hydrogen ions are continuously produced and excreted. If excretion fails, the patient develops metabolic acidosis. So there are 4 main causes of metabolic acidosis: increased loss of bicarbonate, like in diarrhea; increased acid production, as in DKA; infusion of acids; and failure to excrete, as in renal failure. So in this case, how can we determine the cause of metabolic acidosis? So there is where the Anon gap become important. Definitely history is also very important. So now what is an Anon gap? Before explaining, let me tell you a story to help you remember it. There was a lady who owned 2 shops in a village, shop 1 and shop 2. She used the first shop for herself, which had only 1 room. The second shop, which had 3 rooms, she rented out. Both shops were used exclusively to store and sell only fruits. In her single room shop, she always kept exactly 100 fruits. For the rented shop, she set a rule: her tenant also had to keep exactly 100 fruits in total across the 3 rooms. So if one room in the rented shop had 50 apples, the other 2 rooms combined should have only 50 fruits to keep the total at 100. If the first room had 80 mangoes and the second room contained 10 apples, then the third room could have only 10 fruits regardless of type. Every day the shopkeeper checked the number of fruits in each room. However, there was a problem. The third room was always locked, so she could not see the exact number of fruits inside. So then the owner got an idea. She had come up with a formula to find out how many fruits were in the third room, and she named the formula as fruit gap. What is fruit gap? Actually, there is no physical gap. The formula is 100 minus fruits in the first room plus fruits in the second room. This formula let her calculate the amount of fruit in the third room without directly seeing it. For example, if the shop had 100 apples, then fruit gap will be amount of apple minus amount of mangoes plus amount of oranges. This gap value represents the number of fruits in the third room. In reality, there is no actual gap. The formula is just a way to estimate the fruit count in the unseen third room. Okay, now let's understand what is Anon gap in ABG. So in the Anon gap, there is no literal gap as such. Our body contains positive charged particles, cations, and negatively charged particles, the anions. These cations and anions should be equal in number to maintain electroneutrality. For example, if the number of positively charged particles is 100, the number of negatively charged particles should also be 100. So what are the positively charged particles? They include electrolytes like sodium, potassium, magnesium, etc. And the negatively charged particles include chloride, bicarb, etc. Both types of particles must remain balanced to maintain electroneutrality. The measured values of these ions are typically obtained from the labs. However, our body also contains unmeasured anions and cations that are not routinely measured in labs. Example of these include phosphate, sulfate, etc. So in positive charged cations, sodium is a major cation and we have 140 milliequivalent per liter. But since potassium is negligibly small, we won't use for calculation. And we have negative charge anions like chloride of 104 and bicarb of 24 milliequivalent per liter. These 3 values we measure in labs. And there are a lot of unmeasured anions that we won't measure routinely, like phosphate, proteins, sulfate. So how to calculate these unmeasured anions and why to calculate? To calculate Anon gap, we use the formula sodium minus chloride plus bicarb. The value that we get is the unmeasured anion and we call this as Anon gap. And the normal value is 12 plus or minus 2. So Anon gap is the amount of unmeasured anions. Normal value is 12 plus or minus 2. And why do we want to calculate this value? Because in a lot of conditions, this Anon gap value can be high or normal or low. For example, in sepsis, this will be high. In diarrhea, it will be normal, and in some toxicity and in many other conditions, it can be very low. So once more, how to calculate Anon gap? It is calculated using the formula sodium minus chloride plus bicarb. Normal value is 12. So what are the conditions with high Anon gap metabolic acidosis? It includes the mnemonic, clumpies, K for ketoacidosis, lactic acidosis, uremia, methanol poisoning, paraldehyde, isoniazid toxicity, ethylene glycol poisoning, salicylate toxicity. So what are the conditions in which patient presents with normal Anon gap metabolic acidosis? It includes many conditions like diarrhea, renal tubular acidosis, hyperalimentation and many more. And now what are the conditions with low Anon gap metabolic acidosis? It includes lithium toxicity, bromide intoxication, hypertriglyceridemia and many more conditions can present with low Anon gap metabolic acidosis. So in our case, when we calculate the Anon gap, it comes to a lower range. So here one of the probable diagnosis could be a bromide intoxication or lithium toxicity. So we discussed about Anon gap. Now what is delta Anon gap and why to calculate it? Delta basically means difference. We calculate delta Anon gap to know whether the patient has mixed disorder. For example, this patient has presented with sepsis with continuous vomiting and he has an underlying Cushing syndrome. He has developed high Anon gap metabolic acidosis because of sepsis and has developed metabolic alkalosis because of vomiting. So this is a mixed disorder. So to find mixed disorder, we use delta Anon gap. See this patient has a high Anon gap, for example 20. So we calculate it by using the formula sodium minus chloride plus bicarb. What's the normal Anon gap? It's 12. And the difference is the delta Anon gap, 20 minus 12. That comes to 8. So delta Anon gap is 8. And now what is delta bicarb? It's a bicarb difference. Same, this is a normal bicarb and just minus with the patient's bicarb. So the difference is the delta bicarb. So now you have the delta Anon gap and delta bicarb. If you divide delta Anon gap by delta bicarb, you get that gap ratio. If the gap ratio is between 1 and 2, it suggests a pure high Anon gap metabolic acidosis, such as in diabetic ketoacidosis. If the ratio is less than 1, it indicates a concurrent normal Anon gap metabolic acidosis, such as from diarrhea or renal tubular acidosis. And if the ratio is greater than 2, it suggests a concurrent metabolic alkalosis or chronic respiratory acidosis. Delta Anon gap used to calculate to find whether the patient has associated mixed disorder. There is another simple method to know the presence of mixed disorder. For example, in this ABG, this patient has metabolic acidosis. First calculate the Anon gap, sodium minus chloride plus bicarb. Suppose it comes to 28. Now calculate the delta Anon gap. Just minus the calculate Anon gap with normal Anon gap, which comes to 16. If you add this delta Anon gap 16 with the patient bicarb, if you get a value of 24, that means the patient has only high Anon gap metabolic acidosis. But if the value is more than 24, like in our case, then the patient has a high Anon gap metabolic acidosis with metabolic alkalosis also. And if you get a value that is less than 24, then the patient has associated non-Anon gap metabolic acidosis also. So basically we do delta Anon gap to know the presence of mixed disorders. Anon gap is used to identify the cause of metabolic acidosis. So today we discussed mainly what are the 4 types of metabolic acidosis and also discuss about Anon gap and delta Anon gap.